Hello, good evening. This is Dr. Rajiv Raut speaking. The preoperative preparation of this patient starts with use of eye drop drops twice and attachment of pupillo to the spectacle frame as shown. The next step in this surgery is to give pinpoint anesthesia. One looks at the upper temporal quadrant and finds out where the vessels from lower side and the upper side get thinned out and meet and cause a kind of avascular area. This is the place where there is least vascularity and the least sensation. The patient is treated with 4% drops of paracaine before starting the process. Now I have chosen the exact surface marking, taken a small nick in the conjunctiva, then I have taken a small nick in the tenon. Now I am going to insert the outer jacket of intracath number 24 and it will go straight into the intraconal space provided my plane is right. To get the right plane, one has to find the right surface marking and one has to properly lift the tenons so that bare sclera can be seen. The outer jacket of intracath has gone in without any resistance. 2 ml of xylocaine with sensacaine with adrenaline has been injected. The patient feels no pain whatsoever. Now this being a true retrobulbar anesthesia, the effect comes instantly. To start the conjunctival incision, one has to choose, one must choose to incise only the conjunctiva and not the tenon. This is possible only when you choose to incise the conjunctiva on the cornea. There is no tenons on the cornea. I have left this video practically unedited and only those who have plenty of time can look at it peacefully, but it shows every step in a normal routine case. Now we incise all the attachments between the conjunctiva and the tenons. There are well-defined attachments between conjunctiva and tenons and they are incised by giving traction on the conjunctiva Now the tenons is still in place and under the tenons one can see certain large blood vessels. Now this is called pre-tenon cautery. I use heat cautery and not bipolar cautery because the heat has to go through the tenons. It will be impossible with a bipolar cautery. Now by cauterizing the large vessels, we have removed the perfusion pressure in the system. The next step is to remove anterior 2 millimeters of the tenon so that it never rolls and causes any foreign body sensation. Now once we remove 2 millimeters of the tenon, all the small episcleral vessels will be visible. They won't bleed much because we have already removed the perfusion pressure in the system. The temperature of the cautery is standardized by holding the cautery on a spirit lamp and putting a stopwatch on that spirit lamp. Normally we heat the cautery for 15 seconds before using it, and we use a new cautery every 30 days. The incision is marked by calipers. One should never take a SICS incision without marking it. The incision will be centered on the broadest part of the limbus, the blue zone, so that it corresponds properly with the root of the iris. The length of the incision is decided by the age of the patient. It is decided by the thickness of the lens which the A scan shows us, and it is also decided by looking at the slit lamp findings. The standard length is 6 millimeters. For age above 80, I add a half millimeter. For lens thickness above 4.8 millimeters, I add another half millimeter. So sometimes I'll end up with an incision sign of 7 millimeters. In a young patient with a soft nucleus, the incision size may be reduced by half millimeter, and then it may be 5.5 millimeters. The initial entry of the crescent knife is guided by staying under the very fine episcleral vessels which can be seen through the microscope. It is important not to depend on translucency to understand the depth of the incision. It's very important to keep the small blood vessels traversing on the sclera and towards the cornea as the guiding depth marker. Is very important because then one never gets an anterior or a posterior perforation. How much to enter into the cornea is decided by the anterior chamber angle which I get from the pentacam. Narrow angle, enter the cornea more. Big open angle, enter the cornea less. So that one has almost the same amount of space in every case. The illuminated keratoscope.
Intended flat meridian 70 degrees. Current flat meridian 27 degrees.
In the center.
Current flat meridian 71 degrees. Current flat meridian 0 degrees. Current flat meridian 50 degrees. Intended flat meridian 70 degrees. Current flat meridian 0 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 degrees. Intended flat meridian 70 degrees. Current flat meridian 0 degrees. Current flat meridian 0 degrees. Current flat meridian 89 degrees. Current flat meridian 27 degrees. Intended flat meridian 70 degrees. Current flat meridian 0 degrees. Current flat meridian 150 degrees. Current flat meridian 81 degrees. Current flat meridian 45 degrees. Intended flat meridian 70 degrees. Current flat meridian 83 degrees. Current flat meridian 0 degrees. Current flat meridian 45 degrees. Current flat meridian 44 degrees.
The software
Intended flat
continuously
meridian 70
announces where the
degrees.
flat meridian
Current
is.
flat meridian 114 degrees. Current flat meridian 90 degrees. Current flat meridian 0 degrees. Current flat meridian 55 degrees. Intended flat meridian 70 degrees.
I
Current
stretch the
flat meridian
cornea
33
horizontally
degrees.
as much as possible
Current flat
by
meridian 0
injecting
degrees. Current flat
viscoelastic at
meridian
3 and 9
77
o'clock.
degrees. Current flat meridian 107 degrees. Intended flat meridian 70 degrees.
The flat now
Current
the
flat meridian
before
78
entering
degrees.
and extending the
Current flat
incision
meridian 10
by
degrees.
the pressure from the
Current
top by
flat
the
meridian
forceps.
37
I
degrees.
again make sure that
Current flat
the
meridian
upper
38
circle
degrees.
becomes flatter.
Intended flat
See
meridian
this.
70 degrees.
This
Current
gives
flat
better
meridian 0
bifocality
degrees.
in every case.
Current
Most
flat
of the
meridian
patients
0
are
degrees. Current
N8
flat meridian
or
0 degrees.
N10, which is
Current
enough
flat
mobile
meridian
phone
0
vision.
degrees. Intended flat meridian 70 degrees. Current flat meridian 0
You can
degrees.
see that the pupil is
Current
beautifully
flat meridian
dilated.
6.
While before starting the capsulorhexis, one examines the eye and checks for any anteriorly inserted zonules. Now in this case, you can see that at about 6 o'clock, there are some anteriorly inserted zonules. If my capsulorhexis goes there, it is very likely to develop a radial tear. But I can see those zonules because the pupil is beautifully dilated, and therefore I will dodge those zonules. Whether to use the needle or the forceps. If the nucleus is hard and you have good purchase, one can use the needle. If the nucleus is soft and there is no purchase to the tip of the needle, then better control is achieved by the forceps. In SICS, it is very important that one has a good capsulorhexis. Now the 3 and 9 o'clock areas of the anterior capsule will be treated by very low intensity ultraviolet light so as to loosen the anterior lens epithelial cells, because I want to remove them at the end of the surgery. So it's like an incision in the cells which will give me a proper plane when I want to remove those cells, and they'll come out as a single layer. Hydrodissection always at 11 o'clock, not at 3 or 9 o'clock initially. But the fluid wave is not allowed to travel up from the other side. A very gentle hydrodissection is important, just to dissect. Then the next hydrodissection I do on the left or the right, so that the nucleus prolapses out of the bag on one side. It's an unedited case, so kindly excuse these wasted moments where you have nothing to see. Now one prolapses the nucleus out of the bag completely, brings it into the anterior chamber. I put visco above and under this nucleus. Now this nucleus will be chopped by two instruments. The vectis goes under it. One has to be very careful that one doesn't engage the inferior capsular axis. The chopping is very simple. It never has made a complication in any of my cases. Only one should not engage the lower capsular axis margin with the vectis. The second half of the nucleus will usually come out by viscoexpression because it's half the size. It's come out by simple viscoexpression. The next step is aspiration of the cortex. The cortex is attached to each other and attached to the anterior capsule at generally 5 o'clock and 7 o'clock. So the first place to remove it is 5 and 7, not the 6 o'clock. This way we split the nucleus into 3 parts respecting the triangle. We have already dissected the upper part of the Y while doing hydrodissection. When this inverted Y is respected, the rest of the cortex simply flows into the cannula. You don't have to do anything. This is a Gueda Simcoe with 0.3 millimeters aspiration port, and it works in all cases. I have not had to change to a bigger or a smaller port, but the Simcoe from Gueda or from Epsilon in India, quite good. There is a big difference in the price also. If you ask for Simcoe from Epsilon, there is a guy, their engineer called Mr. Sham. Please give him my reference. Tell him you want exactly the Simcoe which I have designed. They have the drawing and they'll give it to you. I don't have any commercial interest in the cannula. The next step is removal of the anterior capsular cells to prevent postoperative antigenic reactions, capsule contraction syndrome because of the fibrosis as a consequence of the antigenicity of the lens epithelial cells, and basically a desire to have a quiet eye postoperatively. Usually I give steroid drops only 3 times a day and stop them after 4 weeks. It's possible only because all the anterior capsule cells are properly removed in the lower half. So there is a low intensity ultraviolet light which is brought under the anterior capsule from a light source. This light source is available with OMS. Again, no commercial interest. They provide these disposable, sorry, not disposable, but sterile hand pieces. So now we have irradiated the anterior capsular cells. But nowadays I even wash them out with an instrument called finger sweep. It's a sharp instrument like a blade. I find it so important to remove these cells that I literally scrape them out. It's an irrigated finger sweep, so you don't really see the cells coming out. You will only see them on slit lamp on the next day. And you will be pleasantly surprised to see how clean the eye and the capsule looks. And it will remain like this forever because there are no cells, so there is no proliferation. These anterior capsule cells are a very strong antigen, and once if the patient starts getting antigen antibody reaction, he can have a painful eye for years with different complaints like pain, redness, foreign body sensation, and after doing a excellent surgery, you lose this patient only because you left some cells inside. This is important to do only in the lower half because, as you know, antigens and antibodies are high molecular weight proteins and they start the trouble only in the inferior half because of gravity. The next step is to implant the IOL. Now, while implanting the IOL, it's important to implant the IOL with the left hand, not with the right hand. So the right hand puts the IOL inside and the left hand will tuck the tip under the bag. It's a very important trick because if you don't tuck it properly, if the tip is not going in properly with the left hand, then you never know where the haptic will land and the lens will never sit in the right place. Even if I have put it under vision, it is important to dial this lens at least through 270 degrees so that we are sure the haptics are not folded onto themselves, and sometimes if there is any undetected cortex in the bag, the dialing of this IOL will bring the cortex out. Since we use the pupillo, we don't have any problem of pupil dropping during surgery. And you can see how beautifully one can view the capsulorhexis and the placement of the IOL. Now that the lens has been dialed by 270 degrees, and because I am 100% sure there is no folding of the haptics onto themselves, one removes the visco and one is finished the case, but not yet. We have to also take care of the post-operative foreign body sensation. So if you look at the conjunctiva, we have removed the tenon and now see how much extra conjunctiva is there. This excess conjunctiva will cause some folds and it will cause foreign body sensation in the post-operative period. This excess conjunctiva must be removed so that the patient never complains of any foreign body sensation. That's it. A simple touch with thermal cautery is enough to restore the conjunctiva. This is the patient as he looks today.